treating diabetes is a real challenge. This is, in fact, very well known to every physician dealing with diabetic patients. So today we will talk about the challenge of diabetes, both type 1 and type 2. In fact, despite the emergence during the last decade of many newer anti-diabetic agents, both oral and injectable, diabetes remains a challenge, and actually a relatively low percentage of diabetic patients achieve glycemic and cardiovascular safety targets. So we know that diabetes remains the 9th major cause of death globally, while 27% of patients with type 2 diabetes have macrovascular complications, 54%, more than half, have microvascular complications, and at least the quarter have chronic kidney disease. These are numbers from the International Diabetes Federation in a large population of patients with type 2 diabetes, noting that the majority, at least 40 to 70% of these patients fail to achieve the A1C goal of less than 7%. Also, the majority have additional risk factors, overweight or obesity, high blood pressure, high LDL cholesterol, and at least 2 to 3 times greater risk of cardiovascular disease. This is also true in our regions. This is the Discover, it's in fact true worldwide. This is the Discover study conducted in Eastern Mediterranean countries and in Lebanon. And we can see, I will skip this slide to tell you that according to the Discover study, at the time of initiation of second-line therapy, usually after metformin in patients with type 2 diabetes, mean A1C level was already 8.5%, mean duration of diabetes 6.7 years, and mean BMI like 30 kilograms per quarter meter. So this is typical of therapeutic inertia. Also, this study was conducted at the American University of Beirut, and we can see that no more than 30% of patients with type 2 diabetes had the A1C goal of less than 7%, while like 40% had A1C over 8%. Now, why is that? One important issue, as already said, is the therapeutic inertia. As we can see on the slide, various studies have shown that it can take longer than 1 year for type 2 patients who are uncontrolled to receive additional therapy second line after metformin, and to receive a third oral, it may take up to 3 years. And of course, inertia is here when adding oral therapy, but inertia is even more accentuated when we have to start insulin in those patients who are insufficiently controlled on orals. As we can see, at insulin initiation, the average patient had 5 years with A1C over 8 and 10 years with A1C over 7%. This, despite the fact that there are now recent data strongly suggesting the need for intensifying diabetic therapy very early on in order to maintain optimal glycemic control and then preventing diabetic complications. While, as we can see here, the current approach waits too long and keeps A1C high, insufficiently low, so high for enough time for the complications to develop. Why also this happens? What are the major barriers to optimal diabetic control? One important barrier is, of course, we all know, fear of hypoglycemia, fear of weight gain, the complexity and lack of flexibility of therapeutic regimens, lack of educational support, and the expenses of the treatment. Hypoglycemia is a major barrier. As we can see here, a very important percentage of patients were found to modify their insulin dose without seeking medical advice after experiencing an episode of hypoglycemia, whether mild or severe. Also, the great majority of physicians, both PCPs and specialists, say they would treat their patients more aggressively if they didn't have the concern about hypoglycemia. Now, more specifically for type 1 patients, there are, of course, limitations of insulin therapy. To start with, the burden of multiple daily injections and of self-monitoring blood glucose, the lack of flexibility of certain therapeutic insulin regimens, again, the fear of hypoglycemia, so that many patients are willing to accept suboptimal glycemic control in an effort to avoid further hypoglycemic events, the variability of the glucose-lowering effect of insulin therapy, both inter and intra-patient, and the expenses of the treatment, mainly the newer insulin analogs, which are associated with less hypoglycemia and lower variability and more flexibility, but of course are more expensive. Also, the newer techniques of continuous blood monitoring, which are less invasive but more expensive, pump therapy, etc. Now, in Lebanon, so to end up with a bright perspective, we had a very good experience, a positive experience with patients with type 1 diabetes with the Chronic Care Center. The Chronic Care Center is, in fact, a non-profit institution which offers a multidisciplinary approach for young patients with type 1 diabetes. So for these patients, self-monitoring equipments are always provided almost without cost, without any cost. Also, the newer methods of patient education and empowerment are implemented. All type of insulin and insulin pens are provided, as well as continuous glucose monitoring systems and insulin pumps when needed. Of course, we have some organization to support the center to help us provide all this, in addition to a research lab. And this approach proved to be very efficient. We can see that our average during the year of A1C is around 8, which is among the best reported in the literature. Also, we have lower complications, retinopathy, nephropathy, even lower than that reported in the literature, and our patient compliance is is good. So to conclude on all this, treating diabetes remains a challenge in both type 1 and type 2, despite the availability of many newer therapeutic options. Many barriers stand against achieving glycemic targets in the majority of patients, despite improvement in these therapeutic tools. A multidisciplinary approach, as experienced at the Chronic Care Center, as well as psychological and financial support, should reduce the proportion of failures and improve our results in diabetes, and then reduce diabetic complications. And with this, I thank you for your attention.